now, and then we will have formal introductions. Okay. So good afternoon, everybody. My name is Lauren Malcolm. I'm the co-president and co-founder of Coalition to Cure CHD2. We are super excited to present to you Dr. Ingrid Scheffer, who is a pediatric neurologist and clinician scientist, and she's also the president of the Australian Academy of Health and Medical Sciences, and she is responsible for helping to discover the first gene associated with epilepsy. So we are, again, excited to welcome you, Dr. Scheffer, and really I'm interested to hear your talk on CHD2. Thank you.
Thank you very much, Lauren. Now, you are very broken up to me, and I'm not sure if I'm coming back broken up. So if I am, please, whoever's listening, break in and say, can you say that again? Because I'm on the other side of the earth, as you all know. And I think we have some of the Australian families on, which is really nice as well. Okay, so I was asked specifically to talk about the clinical aspects of CHD2 epilepsies, and I've focused this at the very severe end, the developmental and epileptic encephalopathies. And my screen is not, here we are. So I like to think about the very complex group of epilepsies that we call the developmental and epileptic encephalopathies as sort of a puzzle because of their complexity. And the reason for that is to help people to make a diagnosis, because otherwise it's difficult, and clinicians struggle to be able to say, does it make sense that this child has CHD2 disease? So I put together a puzzle many years ago for Dravet syndrome to teach people to recognize Dravet syndrome. And I think that has been well used around the world as a concept. And I did one also for CHD2, suggesting that the very severe end that I'm going to focus on begins between 1 and 4 years of age, that one of the hallmarks is clonic seizures, and I'm going to walk through different seizure types with you, that you can have absence, generalized tonic-clonic seizures, tonic, and a new seizure type that we described in our work on CHD2 called an atonic myoclonic absence. You can have intellectual disability ranging from mild to severe to even profound, and autism spectrum disorder. They have a very key feature, and that might help with diagnosis. I don't think it's specific to CHD2, but it's very rare. I've only seen it with CHD2. And this is this self-induction or clinical photosensitivity, where they'll go up to a TV screen to induce seizures. And I'm going to show one of my patients doing that. They have very prominent generalized polyspike wave on EEG. And obviously, to have this disease, you have to have a CHD2 mutation. And in most of the children with the severe phenotype, it's a new mutation, which is what de novo means in that child, a mutation being a genetic abnormality. So before I go dive into CHD2, I thought it was really important to talk to you about what we mean by this complex term, developmental and epileptic encephalopathy, because that underpins the thinking about the disease and also the urgency about trying to get good treatments for this very serious disease. So I've been integrally involved with the International League Against Epilepsy, which is the world medical body for epilepsy, and its classification commission, which I led, I think, 2009 to 2013. But then this led to the first new classification of the epilepsies in about 30 years. In 2010, we actually tried to delineate what this phrase epileptic encephalopathy means. And so the encephalopathy is a big word, and basically this means brain, enceph, pathy means disorder of the brain. So all that means is a brain disorder, big word, but a very straightforward meaning. The important bit is the word epileptic, and this is because the epileptic activity itself is affecting the child's ability to learn, often with behavioural effects as well, but not always. And that's more than you might see if you look at the brain alone. So if you look at the MRI and it shows a cortical malformation, the brain hasn't formed right, it might be very small, but the child might have this very severe consequence of poor learning and perhaps poor behaviour. And I've got this definition on the back of an EEG that is showing a Lennox-Gastaut picture where there are discharges throughout the EEG, right, the whole brain, generalised we call that, and these dark green lines denote a second, and you can see there's a discharge here, a discharge here, a discharge here. So every second this child or adult's brain is being pummeled, if you like, by epileptic activity, which is stopping the child learning and developing. So the concept is really important because it shows it's much more than just the seizures. So to help understand this concept of an epileptic encephalopathy, I made it into a triad to teach doctors and families about this. And these three features are usual, but not always. So you usually have seizures, you don't always have seizures. You must have epileptic activity in the brain, and these must impact on development, and that involves slowing or actual loss of skills. So just pulling the concept of the triad apart, seizures. Well, most of the children present with seizures. That means they come along and recognise with seizures. They often have multiple seizure types, which is quite common for the children with CHD2, and they may have a combination of seizures, and we'll go into that. They may all of a sudden begin at once, like the child's fine, and then at 3 years of age, they suddenly get one seizure type and a week later another, and often they might even be missed. They might, the doctors might recognise the tonic, clonic seizures, but might miss the little absence seizures or the little jerks. Or they may have a gradual onset, such as Dravet syndrome, which we've just published a big paper showing that some of the seizures, some of the children may not have 6 months between their first few seizures, so much more gradual. In some of these epileptic encephalopathies, the child might only have one seizure type, such as absence seizures with eyelid myoclonias, and that is highly relevant to CHD2, and I'm going to return to that towards the end of my talk. And equally, there are rare syndromes where you don't actually even have to have a seizure. You do have to have the epileptic activity, but you may not have a seizure. The second part of this triad is that you have to have frequent epileptiform activity. So sometimes people get referred, or children get referred because of an epileptic encephalopathy, but they've never had epileptic activity on their EEG, which means they actually do not have an epileptiform, do not have an epileptic encephalopathy. Now, there are some very distinctive patterns that people like me get very good at recognising, and one of those was the slow spike wave I just showed you for Lennox-Gastaut syndrome. Another one is called hypsarrhythmia, which is typical for epileptic spasms, and that has become relevant to CHD2 as well. And then multifocal discharge is also a common pattern. These patterns may have specific timing. For example, children with West syndrome, epileptic spasms, present at 6 months with hypsarrhythmia. But by 3 or 4 years, many of them have evolved, about 50% in fact, to Lennox-Gastaut with slow spike wave. And just to reiterate, if you've never had epileptiform activity, then you don't have an epileptic encephalopathy. Now, what about the impact on development? This is also absolutely central to this concept. And this can be in a baby with normal development, or a child with normal development who then loses abilities or just stops developing, or it can be in a child with abnormal development who still also stops developing or goes backwards. And this can happen in a stepwise way or can just be once. The most common trigger for this developmental effect are seizures, but it could be infection. We've shown it with brain edema in Dravet syndrome, and certainly with vaccination. So this is what I've just been talking about, but to try and get it across in a picture form. And here you can see a lovely little 21-month-old girl who, when I met, was having a seizure every 5 minutes, and she had a very severe epileptic encephalopathy very frequent epileptic activity. And although her development had never been normal, she then showed loss of all her skills. And you can say, well, why does this matter? Well, it matters because perhaps there's something we can do about it to try and stop this process and help the child get on and develop. So one example is the one here where there are structural abnormalities on the MRI. And this is a cut. I hope you can still see me because I'm showing you where the cut is through the brain on an MRI. And if you look here, you can see all these white patches, and these are tubers in tuberous sclerosis. And we know that if you can take that child to epilepsy surgery and you can find out with a lot of work which of these tubers are causing seizures, perhaps just this one is and the others are not, then you resect that, you can actually resolve this process of epileptic encephalopathy and the child can get on with development. So that's if there's a structural cause. But what happens if there's a genetic cause, such as CHD2? Well, it's similar because if you know that there's a particular genetic cause, and here I'm showing you a potassium channel, which is mutated in a disease called KCNQ2, developmental and epileptic encephalopathy. We know that high-dose sodium channel blockers such as Tegretol, carbamazepine, or phenytoin, Dilantin, if you use those two and get them up to high levels, you can actually improve the outcome of these children because they can get on with developmental progress. So the concept is very important. Now, in 2017, in the classification that I led for the International League, we expanded the concept from an epileptic encephalopathy to a developmental and epileptic encephalopathy. And this was because as we discovered more and more genes for epilepsy, we realized that many of them caused developmental impairments in their own right. And then the child had slow development, then you got this severe epilepsy on top of it. And that, of course, led to more developmental slowing. Now, the difficult part, and one of the key issues that I hope you take home from this talk, is that there's a broad spectrum of presentations for every gene. So it's not just one gene, one syndrome. One gene has many syndromes. And often these disorders are associated with a wide range of comorbidities, such as this little boy I'm showing you here with the potassium channel developmental and epileptic encephalopathy. And you can see he's got severe cerebral palsy and profound impairment. So now I'm encouraging doctors to make diagnoses about both the gene name. So for this audience, it would be CHD2 developmental and epileptic encephalopathy. But we also need to understand the epilepsy syndrome in order to make sure that, that we're treating the syndrome appropriately. Oh, sorry, my computer just wants to do an upgrade, believe it or not. Now, within the developmental and epileptic encephalopathies, there's not just one syndrome, there are many. So the best known ones would be myoclonic atonic epilepsy, described by Dozer, Dravet, Lennox-Gastaut, West syndrome. But there are many others that are smaller print, so much less common. There are ones that are more focal. But it's important to recognize, and there are some that start later in life, such as the progressive myoclonus epilepsy, is also extremely rare. But it's important to realize that there are many of the patients that don't fit into a nice little box. And there are the early infantile group beginning under 3 months of age, the infantile group between 3 months and 2 years, and then recognizing that this can happen at any age in life. So if you don't fit a syndrome, it doesn't matter. It's more important about recognizing that they have such a severe process that needs very active management. So why is this hard? Well, it's hard because we now know there are more than 400 genes causing these developmental and epileptic encephalopathies, of which CHD2 is just one. And this picture is taken from a review we published back in 2016 when there were about 60 genes. So you can tell it's absolutely exploded since then. And I'm just trying to see where CHD2 is, but it's not jumping out on me. It should be on here somewhere. So just to say that there are now many different, oh, here it is, I found it, cell biology processes that are involved in causing these severe epilepsies. So we need to break them down to different genes to understand the mechanisms, to develop precision therapies. So I just want to belabor a few of these points a little to make it really clear. So the genetic epilepsies have a broad spectrum of mild self-limited epilepsies. We used to use the term benign, and the severe end, the developmental and epileptic encephalopathies. And unfortunately for the doctors, and it's not straightforward, one syndrome, epilepsy syndrome, does not equal one disease. So if you take a particular gene, it will have this spectrum of mild to severe. And if you take one of the best known genes, SCM1A, and I'm just using that because it's probably the poster child in this group of diseases, it causes a mild end, which is something that came out of my PhD a long time ago, genetic epilepsy with febrile seizures plus. But at this end, it doesn't just cause one developmental and epileptic encephalopathy, it causes 4 different ones. The best known, the poster child being Dravet syndrome, but it can also cause myoclonic tonic and a very severe form that we described a few years ago. So one gene, many syndromes. Let's look at it the other way. What about one syndrome? Well, yes, there are also many genes. So this is the little girl I just showed you in the picture having a seizure in front of me. She fitted into this syndrome and had SCN2A. But you can see in this particular syndrome, we now have 33 genes and a third of patients remain to be solved. And those 33 genes, we did a big international collaborative study on this of 135 patients. And you can see in blue that half of them had dominant diseases, brown about a quarter had recessive diseases, and in green some had X-linked. So this refers to different inheritance patterns, just to show you how complex it is. And is it always like that? Well, no, in this particular syndrome, 70% are solved. In Dravet now, in our recent paper, we found that more than 90% are solved and more than 90% have one gene, but this is the rare one. Most of them have many genes. So some people will say, well, so what? Why does it matter to know the cause? And I think it makes a huge difference and is incredibly important in taking the field forward so that we can get treatments which are targeted. So firstly, why it matters is it ends the diagnostic odyssey for families. And as I'm sure everyone on this call knows, that is long and difficult, and you wonder what went wrong. Is there something you could have done to save your child having this dreadful disease? Is there something that you could have done about it? I never say it is the answer. My words are it's the beginning of the answer. Once you know the gene, you can then think about how am I going to address this directly. It also informs, if you know the gene, what comorbidities you should look for. And that means what other features. It's just a fancy medical word for other features. So are there gait problems? Are there behavioural problems? Are there issues like psychosis? Are there gut problems? Are there sleep problems? Does my child have an increased morbidity? So a whole lot of other things, not morbidity, I meant mortality. So what's the prognosis for my child? Will they make old bones? Those sorts of questions. So how does this help? Well, it helps today in optimizing treatment. And you might say, well, you know, how does that make a difference? Well, we have a selection of anti-seizure medicines. And if you know a child has a specific gene, you can look at the literature, say which particular drugs help this disease and which ones are bad for it. And we see this all the time today in Dravet syndrome, where doctors don't think about Dravet syndrome, they give them Tegretol and the child gets worse, or carbamazepine. And yet if you gave them the right drug, you wouldn't make the child worse. So it's very pertinent today in the clinic. You know, I'm going to clinic this afternoon. It's relating to my clinic activities today. And also incredibly important for genetic counselling purposes, because if a family has one child with a severe epilepsy, can you imagine how hard it is for them to have two? And we did some interesting work on this a couple of years ago, if you'd like me to talk about that in the question time. I also wanted to talk about the range of comorbidities that goes with all these severe epilepsies. I mentioned them all a while ago, but often as the child grows older, the parents are fantastic at managing the seizures and all the other things, but maybe the behavior makes it really difficult, and or the autism or so many other features that are really hard. So when we talk about targeted therapies and precision medicines, that is the big hope. And it's really important because we're talking about treating a lot more than seizures. We want to treat everything because the aim would be to have a child who has had a normal outcome. And at the moment, we're a long way from that, but I think gene therapy does hold that promise. So that's the background. I'm sorry it was quite long, but I think it needed to understand the context of what I'm going to talk about. And I was fortunate to be involved with Heather Mefford and Gemma Carville in discovering that CHD2 was a gene for severe epilepsy. And in this paper, Heather and Gemma looked at patients who'd had a copy number variant where they were missing or they had an extra copy of part of a chromosome. And they looked in on those and said, which genes are in those areas that are missing, which could be important. And then they went and sequenced a whole heap of genes in this study. And the two big newcomers that we discovered here were CHD2 and SYNGAP1, as you can see here. And here is the one we're focused on today. Now, it's important to say that this was 500 unsolved patients that we looked at, which were largely through my research program, which is why I was so heavily involved. And you can see SCN1A is there, but remembering that many of the clear-cut Draves were taken out. So these are ones that didn't look quite like a Dravet that were left in. And so this doesn't mean that CHD2 is X% of all the developmental and epileptic encephalopathies, because these were the ones that we hadn't solved, not the ones we had solved. And many people have misinterpreted that in looking at the data from this paper. So we had, I think, 6 patients, as you can see this, of the 500 with CHD2 and 5 with SYNGAP1. And I hope you know your SYNGAP1 cousins because they do share some similar features. And you can see we found some other genes that were the first discoveries of these for the epilepsies. And I've been involved in doing cohort studies since in CHD2, SYNGAP1 and MBD5. This is from our original paper, and as I'm sure everyone here knows, that CHD2 encodes chromodomain helicase DNA binding protein 2, and it's got a key role in gene expression because it modifies chromatin structure. And you probably know a lot more about this than I do, but that's how the gene is all folded up, and then it gets unfolded. You can transcribe that gene and make more protein, and it therefore will control many genes. And here were the mutations in our original paper. The only other point to point out is that these were the little asterisks, truncation mutations, which means you don't make the protein properly. So 4 of our 6 were truncation and 2 were missense mutations. I then followed up with one of my fellows who was an adult neurologist from Wales who'd come to train with me, and we did this paper on the phenotype of CHD2, Reese has now gone back to the UK. Well, he was with us for a couple of years. Oh, and it was also actually co-led, that's what these asterisks are, with Dr. Zhang, who was a pediatric neurologist who's in Shanghai, back in Shanghai. They're both with me. I think Reese for 2 years and Lynn May for 1 year. So in this cohort of 10 patients, many were from Australia, and I know some of my patients are online or their families, so thank you very much for tuning in. I appreciate that. And these were 10 patients who all had new mutations in them. 9 of them were CHD2 specific abnormalities or mutations, and 1 had this deletion which included CHD2. The mean age at study was 18 years with a range of 6 to 36 years. And this is one of the beauties of having, I think I've been doing this for about 30 years now, which is a long time. And we have patients, many patients I've followed for many years. And so that means you get a really good understanding of their course, but also their seizure types. So the mean age of seizure onset in these 10 patients was just after 2 years. You can see 12 to 42 months. The striking feature was that they all had myoclonic seizures, which are those little jerks, and I'll show you a video in a moment. 9 had absence seizures, which include typical and atypical absence. 4 had a specific type of absence called eyelid myoclonia with absence. 9 of the 10 had generalized tonic-clonic seizures, which began a bit later at a mean of 5 years. 6 presented with status epilepticus, which is defined as a seizure continuing for at least 6 months. And this could be convulsive, where you jerk all over, and having a full convulsion, or it could have been non-convulsive, where you're just off the air, perhaps a bit dribbly, more unsteady than usual. And if it goes for more than half an hour, it's called non-convulsive status epilepticus. Beginning at a mean of 9 years, that can be quite subtle, the non-convulsive status epilepticus. And you can just tell your child's not quite right. And the doctors may not be across it. So it's always good to keep an eye out for that. Of my patients in this cohort, 7 had moderate to severe, even profound intellectual disability. And interestingly, 3 were milder with later onset at 34 months and easier to control epilepsies. So I wanted to talk to you about a new seizure type that we described in this paper, which was a photosensitive seizure type, hence my fancy picture. Oh, now it's not moving on. Here we are. So this is a little chap of around 3 years of age. I think we had 3 patients with this, and you can see him, and he's staring, watching TV. Then he has a drop, an atonic, which means loss of tone. And then he has this jerking of his arms up. There you see both arms at a frequency of 3 per second, which mirrors the EEG. So just to describe that a bit more, I'm not sure if you can see me, Lauren. Can you see me? I'm hoping you can. It begins with a jerk, a fallback, loss of tone, and then this bilateral jerk of both upper limbs as they come up. And I'm going to show you another patient with that in a moment. But just to play that again, because I know it's quick and I'm not sure how well it will go over the internet. We have this, he's watching TV, sudden loss of tone, and then watch his arms here, and you can see they've got this little run of jerking. And the poor little chap is hurt himself and he's not very happy. Same little boy. I said I think it's 3, but I think he's actually 2. And this is a patient of my colleague, Dr. Deepak Gills in Sydney. And you can see he had that jerking of his arms, and then he didn't fall back that time, thankfully. Now here you see one of my patients who likes to self-induce, and we're in the outpatient area, and there was a TV, and he was going up to it. I'm sorry, the perspective's a bit weird on the TV, and he's playing the game, self-inducing, having that loss of tone that you saw, and then the jerking of both arms. So that was a new seizure type that we described in this paper, and you can see here the head dropping forward, and then these 3 discharges, or a bit more actually, but 3 per second of spike wave with those arms going up. That was one patient. This is another patient with the same idea, where the eyes go up and they're bilateral arm jerks. So we reported this exquisite clinical photosensitivity, which I think of as very CHD2. 7 of the patients had it. 6 of them self-induced, just like that little boy, by going up close to the TV. And they are triggered, myoclonic seizures were also triggered by photic stimuli. So what I mean there is the sun flicking through the trees as you drive along the road, often good for the child to wear sunglasses to try and prevent that. And that little one child, I don't think it was this boy I just showed you, self-induced, actually had a tonic-clonic seizure by self-induction with the TV. So what we sometimes recommend is sort of a cage around the TV so they can't get so close. I think the risk of that is much less now with digital TVs. But interestingly, there was a bit of a disconnect here, that only one of them had on EEG the photoparoxysmal response, which we see with photosensitivity. And that is not what you'd expect. You'd expect that if they have it clinically, they should have it on EEG. We can't explain that, but we had a very clear history of clinical photosensitivity, which is where the parent sees it when they're driving along and the child has a few jerks, or you might go from a dark environment to a light, dark inside a house, outside sunny day, or TV. The other places for photic sensitivity are the light on the shower in the bathroom, or at a swimming pool or the beach where the light plays on the water. So all of those areas are more dangerous for these children because they need to be carefully watched in case they should have a seizure. Now here's the last boy I showed you. He's now 18 years of age, and he's just got a little bit of a same seizure type happening now. You see that little jerking of the arms? They don't come up quite as much, but he has these still most days, even though he's now pretty grown up. I'll just play it again so that you can see there. Oh dear, went very fast then. Oh, I'm sorry, now it's not going properly. But anyway, oh, let me try that one from the beginning again. No, I'm sorry about that one. Let's go backwards or forwards. Now I have a real it has actually frozen. Let me try again. Yeah, it's playing properly now. I hope it's playing okay in the US. So he's just having his breakfast. He's playing with his nose. There it is, a very subtle little run of jerks. Same seizure type, but he's grown up and he's not falling with them there. And I think there's another one at the end of the video. Here he is again at 18. And you can see there the arms came up a bit more. He's smiling. I think he sort of knows it's happened. In this
Scheffer?
Yeah.
This is Christine Salmi. I'm not sure about anybody else, but I'm just seeing the view of everybody online and not your screen anymore. So.
Oh, okay.
Yeah.
All right. So maybe I forgot to share. Thank you for saying that. It's terribly sad to not see. Let me try again. I was just trying to play it again. Can you see it now, Christine?
Yes. Thank you.
And I'm just going to play it again then because it's quite good to see his seizure. And there are two versions. There's a little one with the arms coming up with a run of myoclonic jerks. It's called a myoclonic absence. And then in the second video, you'll see that again. You see there, it's a bit more marked, a bit more typical, and those jerks are at 3 Hertz. And he's smiling, he sort of knows it's happened. So in our cohort, they were normal in the first year, but walked just maybe a tiny bit late, some of them. The upper limit of normal walking is 16 months, and they walked all of them by 18 months. Speech delay often preceded seizure onset, which makes sense because you should have single words at 1 year, so that if the mean onset was just after 2 years, speech delay will be evident. 7 had moderate to severe intellectual disability, and 6 regressed, which means goes backwards with onset of seizures in terms of their development. 3 had mild intellectual disability. 4 had autism spectrum disorder. 3 had attention deficit hyperactivity disorder. 8 had very challenging behaviour as they grew up. And 5 developed a crouch gait, and 4 had ataxia, which means unsteadiness. And here shows you 2 patients' MRIs over time. This patient at 12 months had a hypoplastic corpus callosum. This is the band of white matter that joins both hemispheres of the brain, the 2 halves. And you can see this is a little bit shorter than it should be. Between 12 and 23 months, this child showed some thinning or some shrinkage of the back of the brain in the cerebellum, which looks after steadiness and coordination. And here is a bit of shrinking as well. In another patient at 3 years, they have a bit of shrinking of the brain. And the question here is the brain just not grown enough, or has it shrunk? I don't think we really know, but it's more marked at the back of the brain. And here you see also the cerebellum is a bit shrunken. And here there's a little bit more thinning at the back. Here are the mutations that in our cohort of 10 patients, and some described by Arvid Souls, and some in the intellectual disability literature, and this was another epilepsy-related one from the literature. So Reese, Thomas and I put together this picture to try and get across the various features of CHD2 developmental and epileptic encephalopathy. And we ranged them across from the very severe to profound to moderate to mild, showed the association with seizure onset, with the better onsets, the later onsets in the milder patients, showing that photic sensitivity to the environmental flashing lights was really across the group. They all had myoclonic seizures. Most of them had tonic-clonic seizures, generalized tonic-clonic seizures. Many of them had absences of different types. Notably, probably the milder ones had the eyelid myoclonia, which I'll talk about more in a moment. This was our new seizure type of the atonic myoclonic absence. These are the patients with the non-convulsive status epilepticus, again, maybe more towards the severe end, tonic seizures, atonic, so tonic is stiffening all over, atonic is loss of tone, and convulsive status epilepticus, as you can see across. So here you see another little one with their myoclonic absence going on there. And the mum's just realised onset late infancy to 4 years, self-induced myoclonic seizures, this atonic myoclonic absence seizure and multiple seizure types, and intellectual disability. Now, when we were doing all this work, in fact, just after we published the first paper with Gemma and Heather, the Arvid Souls from the De Jonge group also discovered CHD2. So we were obviously both working on it at the same time, which often happens when you've got, good labs doing similar things. Now, their patients were 3 patients. As you can say, their onset was very similar to ours, 14 months to 3.5 years. They said that they shared features with Dravet syndrome. So it's not really Dravet syndrome, it's too late. But the similar thing is seizures with fever. Dravets tend not to cluster, but they can. Simple might be just one. All had myoclonic seizures. They had similar seizure types to the ones I just walked through. All had generalized polyspike wave, which is what ours had. They said 2 were normal. 1 was mild delay prior to seizure onset, so very similar to ours. Mild intellectual disability, 1 with autism and 2 with ataxia. I can't recall the ages, but obviously if a child's younger, you probably don't know quite what the future holds for them. So this led me around that time to develop this table to show really that CHD2 was much more like myoclonic atonic seizures, where you have a jerk and a drop. But the feature of CHD2, that much more like this syndrome than Dravet, because Dravet typically begins around 6 months, but we've just published a paper showing it can go up to 19 months. They often have status, early convulsive status. Photosensitivity is pretty rare. They're also normal. Whereas in myoclonic atonic, you can see that it's also got some very similar features to CHD2. So then I wanted to share with you another study that I then went on to do with Sanjay Sisodia from London. He's an adult genetic neurologist, epilepsy genetics neurologist at Queen Square. And what we did in a large collaboration, as you can see, is put together 580 patients who had clinical and/or electrical photosensitivity. And we found that 11 of 580 patients had unique variants in this gene, in CHD2, compared to far fewer in controls, suggesting that variants in CHD2 were well and truly overrepresented in those people with photosensitivity. And we made the statement that we thought this was the first gene for common photosensitivity. Now, photosensitivity is not common, but for your ordinary photosensitivity, not your very special ones. So I want to show you this patient of mine. She has the, she's about 25 or so there. She has this absence seizure with eyelid myoclonias, where her head extends. She has rapid eyelid fluttering. Now we're going to play this again. I'm going to tell you when it is. So there it is now. She has head extension, eyebrows raised, and eyelid fluttering. There it is again. And one more time, there you can see it's only very brief. And there it is again, just subtly the last one. So she has a drug-resistant photosensitive generalized epilepsy. This syndrome is almost impossible to get under control, though you can occasionally. Some people have a good outcome. Not all of them have CHD2, only a minority. This girl is of borderline intellect. She's now about 35, lives on her own with her parents offering a lot of support. And she has a new mutation in her de novo. So this is referring to her. I just wanted to bring my talk a bit more up to date. So I was looking at some of the literature over the weekend, and this is a paper from a wonderful professor in Beijing who spent a year with me some years ago now, and Professor Zhang and her group have noted 17 patients with CHD2 epilepsies. And they've extended the phenotype, interestingly, to one with a 10.5-year onset, so that's a bit later, to epileptic spasms. In terms of syndrome, they have myoclonic atonic epilepsy, Lennox-Gastaut. They were the first cases with spasms, which are West syndrome. But 2 with very mild epilepsies called febrile seizures. Plus, I mentioned that before as part of SCN1A and a syndrome that came out of my PhD. 9 of their patients were well controlled, and there's a truncation that they found was recurrent, so in more than one individual. And from their paper, again, they looked at the variance in the literature in 70 patients, and of the 70 patients, they found that really the most common is the French shift, which is what I showed you at the beginning of the truncation, where you don't make a proper protein, followed closely by missense, where the code doesn't make sense, ones with a gene deletion, which is where the original interest we found in it, where we found CHD2, nonsense mutation also doesn't make a proper protein, and one with a gene duplication. And they put together, of the 70 patients in the literature with CHD2, 2 did not have epilepsy. I'm sure there are more in other cohorts with just intellectual disability or autism, but they tried to look at the different types of epilepsy in this group. And you can see here that a third of them were unclassified, and that may relate just to the groups reporting them. If they're done by geneticists, they often don't drill down on the epilepsy, so you don't get very good epileptology. In their own group, I think they found 12 where they couldn't put them into a specific box, as I talked about before. The biggest box is myoclonic atonic epilepsy. And this is the other big one I would talk about, the eyelid myoclonia with absence. And the Lennox-Gastaut, this is, I think, from the literature as well. I wanted to share this picture with you because this came out of a paper that I published last year with Hannah Stamberger and the Danish group and a lot of collaborators. And this is a paper that we actually looked at another gene called NEXIMF, N-E-X-I-M-F, but the concept is important and is highly relevant to CHD2. So I now think of, I'm trying to think of it as 3 or 4 different genes, SYNGAP1, CHD2, NEXIMF, and I feel like there's another gene that as soon as I see a child with this overlap, particularly with the myoclonic developmental and epileptic encephalopathy, I say, go and look at these 3 genes, and it's very helpful. And many of the patients have this overlap of this eyelid fluttering, often very frequent, every minute or 2. And so this eyelid myoclonia with absence, and they may also have the drop attack with the myoclonic atonic epilepsy, and they sit here in the middle. So this is, if you see this, you've got to think about CHD2 straight away and these other 2 genes. And I think conceptually that's important for doctors to realise. So I just wanted to finish with this picture of my adult patient. She's 35. She's always been profound. She was profound developmental and epileptic encephalopathy. So she's never walked or talked. She's got a fantastic mother and father, but I know mum much better, but the dad's pretty good too. And interestingly, when she was a newborn baby, mum recalls taking a photo of her, and when they took the photo of her, she jumped. So, you know, even from the very beginning in life, the first few months of life, this girl was showing myoclonic seizures with a photo flash. And, you know, she's right at the very severe end of this disease. And just as an aside, I've had her in my fenfluramine trial, and she's done very well with it, with marked reduction in seizures, improved happiness and alertness. So just to tell you, I guess I'm throwing that in there because I think as a community, CHD2 should be lobbying to try and get studies of their patients, their children, to try and treat them. So I hope I've shown you that at the CHD2 developmental and epileptic encephalopathy, onset is typically 1 to 4 years of age with myoclonic seizures, absence, generalized tonic, clonic, and this other seizure type, mild to severe intellectual disability with autism spectrum disorder. There's self-induction, which is very CHD2, generalized polyspike wave, and of course you need to have a CHD2 mutation. And I'd like to close by thanking all the fantastic people I work with. This is from our last in-person retreat, sadly 2 years ago now, thanks to the pandemic. My fantastic collaborators here at the top, I don't know if you can see it, but there's Heather Mefford and Gemma Carville, and also Dr. Zhang, whose work I just showed you from, and Dr. Sisodia. But of course, most importantly, I want to thank the patients and their families. And I know that at least one, if not two of mine are on this call, and I'm really very grateful to you for your support. Thank you very much. I'm happy to take some questions.
Thank you, Dr. Scheffer. If those on the call have questions, if you could please submit them by via the chat. And
I'm
then
happy for them to come on with video and ask me.
Oh, sure.
It's always lovely to see who's on.
Absolutely. And I'll give them a moment to form their questions. There's 2 of them already in the chat, if you don't mind that I will read them.
Can't do that. Let me see if I can see them. Well, they're not in my chat. Are they just on yours?
Yes, and they actually come from Lauren because she said that her connection might not be too well. So if you don't mind, I'll read it for her. Her first question is it too far off to think that gene therapy or repurposed drugs can help to cure some of the symptoms for CHD2?
Great question, Lauren, and absolutely not. I think the more people become educated about CHD2, the more they'll use the right medications from the get-go. And I think it is really important to have gene testing as soon as possible. And that's changing, thank goodness. One of the good things is this in vitae panel. I don't know if your community knows about that. And there's a website called Beyond or Behind the Seizure, funded by several pharmaceutical companies. And the idea is to get early testing. The reason the pharma companies are funding it is they want people tested early to make diagnoses early so that their new whiz-bang treatments can be used early and they can make money. So just to be clear about that. But I think it's a fantastic resource that is changing the ability to diagnose. And I've just had 2 patients in the last month where it's changed my treatment on the day I've got the result. So I think it really matters. So the more we can get the pediatricians, because it's open to any pediatrician of a child presenting with seizures without fever, a baby under 5 years of age in Australia. I think in America it's under 8 years of age, but you can just Google it and check. So absolutely, you get a gene, you then look at the papers, you go, well, this works, this doesn't work, I shouldn't use this drug. And again, Dravet is a great example because people keep putting them onto carbamazepine and that makes their seizures go kabang, loads of seizures. And if you put them on the right drug, you help to control it. So I think firstly, it helps with the known drugs, but secondly, it will help with sorry, I'm trying to say too much. It will help with trying to use other newer drugs, which is why I just mentioned fenfluramine. And I think as an organization, you should go to the fenfluramine company and ask, which is called Zogenix, and say, you know, there's some improvement. Could you think about a trial? It will take a lot of work because CHD2 is not that common, but the more you can get it for your disease, the better. And I don't know it will work for others, but I can tell you it worked for my young lady I just showed you before. And then, of course, the holy grail is gene therapy, where you get a targeted therapy that's developed for that genetic problem. That's a much bigger ask and needs a lot of research to do. It's certainly happening in Dravet syndrome and in SCN2A, and I suspect in SCN8A and in KCNT1, but I'm not aware of any moves for it in CHD2. You probably know a lot more about that than I do.
Thank you, Dr. Scheffer. Another question that Lauren had is, have you ever seen a patient completely resolve from eyelid myoclonia?
So in terms of CHD2, the only one is the one I showed you, who I've been looking after since she was 16. She's about 36 now. And she certainly hasn't resolved. When I met her, she literally was doing it every second. She was talking to me because they're very short, and she was literally doing it all the time. I put her on valproate and it's reduced. And now in a 20-minute, 30-minute consultation, I probably see 4, so it's not gone. There are certainly people with absence seizures with eyelid myoclonias that I have looked after where it has gone, absolutely. And it took a while, took several years to get it under control with the right medications. And I've got one young woman who's now at university, not CHD2, we don't know her gene. And she's, I think, oh, she might be finished. She's a primary school teacher. She had it quite severely and grew out of it in her mid-teens. And I've got a guy that I look after who's got autism, and he's grown out of it too. But he remains on low amount of medication. I think she does too, actually. So yes, she can grow out of it.
That's great to hear. I have an 18-year-old daughter who has eyelid myoclonia, and it seems like we've always interpreted it to suggest that it could lead to convulsive seizures. Have you seen any connection?
Look, I'm sure it could, but I can tell you, when I think of just the girl and the man and the woman now that I was just referring to, I don't think either of them have ever had a tonic-clonic seizure in their lives. So I don't think it always does. And why is that? It happens in some and not in others. It presumably relates to the underlying network. So, you know, if you've got to 18 years and as she had tonic-clonics otherwise?
Yes, she has.
Oh, well, then I guess, you know, she's not out of the woods. But if somebody gets to 18 years and they've never had a tonic-clonic, then that's a little bit more reassuring. I don't think you could ever say someone will never have one, but there are certainly people with absence seizures with eyelid myoclonias that do not have them ever.
Interesting. Thank you. So, Dr. Scheffer, can you now see in the chat?
I can, thank you. And Liquid Song, thank you for asking the question, the psychiatric aspects of the symptoms. So I guess the most common one would be autism spectrum disorder. And, you know, autism has a sort of a thing around it, an aura around it, but really it's just a behavior. And autism is where you have poor language. Well, if you have intellectual disability, you have poor language, poor social interaction and reciprocity, where you don't reciprocate the social interaction well, and some obsessional features, which might be liking routine. So don't take it as something special, but it is part of CHD2. It's part of most of these developmental and epileptic encephalopathies. And sometimes it's used, I think, incorrectly, just to be fairly Australian blunt, please forgive me. So, you know, like my young lady I showed you at the end who has profound impairment, to say she is autistic is meaningless. She doesn't walk or talk, she doesn't react. She's, you know, how can you call her autistic? You can't. But then in the mild or to moderates to severe pictures, they certainly can have autism spectrum disorder, not all of them. In terms of later psychosis, I'm not aware of any, though in some of the developmental and epileptic encephalopathies, we certainly see that, and I've reported that in something called PCDH19. So the other thing just to touch on in discussing this is, you know, depression is common. It's a third of our population, probably more than that right now with the pandemic in Australia and everyone cooped up. We're all in lockdown over here. But, you know, I think we always need to think about patients with intellectual disability. Could they be depressed? Can you do anything about that? So I don't think CHD2 leads to depression, but I don't think we should not think about it in everybody. And then the next one, Christine, describe between an epileptic spasm and an epileptic seizure. Absolutely. So there are many types of epileptic seizures, and a spasm is just one type of seizure. It's very specific. If I had more time, I'd find you one to show you, but basically I'll try and do it. Hopefully you can see me. You basically have, it looks a bit like a myoclonic jerk, but it's subtly slower. So a myoclonic jerk is a single jerk and it's faster than I can fake. A spasm is, and then slightly slower relaxation. So wrap it up, slightly slower. And the other very key element is it goes in a little series or a cluster, and it tends to get worse and then get better. So it might go, that cluster might be over 2 minutes, or it might be over 20 minutes. So it might just start with a little bit, and then as they go along, and they might be every 10 seconds or 30 seconds, and then they might be more obvious, and then they might go down. And sometimes they can be just a bit of the face or something. Usually they're a bit more than that. And if you have epileptic spasms at 6 months of age, which is the typical onset time, it has a very classical ghastly EEG. It's really abnormal. And so just finding 2 patients with that in Dr. Zhang's paper is very interesting and novel.
Thank you, Dr. Scheffer. I have another question, and I didn't want to bother putting it in a chat. I thought I'd just straight up ask you.
Nice.
You mentioned that it's important to know when you have a genetic-based epilepsy to know the gene as well as the epilepsy syndrome. I don't know if you can speak on the state of medicine in the US, but we had our daughter's genetic report done 2 years ago, and that's when we got the CHD2 diagnosis. But I honestly couldn't tell you what her syndrome is. And is that common for us not to know? And how do doctors go about defining and determining what a patient's epilepsy syndrome is? Is it?
Well, it's the neurologist is the person who should do that. It depends a bit on if your neurologist is good at epilepsy, just to be a bit blunt, and not all are equally good. And particularly when you get to the adult world, a lot of neurologists just see adults with intellectual disability and drug-resistant epilepsy, and they don't even think about it in these terms. But your daughter's epilepsy should have been characterized well when she was a child and growing up. That is just a history. I mean, you can do video EEG monitoring, which I often do in the complex patients, but you don't have to. And the history should tell you if they have tonic, clonic. You said that she did. Eyelid myoclonias with absence, so that would definitely put her into that syndrome. But then did she have drop attacks? Did she have, myoclonic atonic? Maybe she had that common picture, I think, where you have this overlap. So one of the problems, I was impressed with my colleague, Professor Zhang's picture of all the phenotypes, but I also have a little bit of doubt because she's taken it from the literature, and some of the geneticists, I mean, whether they've called the right syndrome, I don't know if I believe it. I believe her work. I don't necessarily believe, depending on whose work it is, to say whether you can characterize what syndrome. So your daughter has CHD2 epilepsy. Does she have a developmental and epileptic encephalopathy? I suspect so. I don't know anything about it, but when you have this eyelid myoclonia, that girl I showed you, my patient with it, she really has a developmental and epileptic encephalopathy because she was having seizures every 5 seconds when I met her. So, that affects your ability to learn, and her EEG was very active. And why does it matter? Because if you're in the very mild end, like Professor Zhang said, there were 2 febrile seizures plus, you wouldn't treat them nearly as aggressively. You might not treat them at all. So it really makes a big difference. Now, Carolyn, you've asked me about the ketogenic diets. So ketogenic diet is the syndrome for which it is most effective is called myoclonic atonic epilepsy, and that is a common presentation for CHD2. So now if I see a child with myoclonic atonic epilepsy, then I would try and get the family towards the diet pretty quickly. Now, the diet is difficult in that if you have a very cooperative little person that will take whatever mum and dad give, it's fine. But if the child is very non-cooperative, it can be really hard and very stressful for the family. So the ketogenic diet is not always doable because of the child and the family. You also need to have very good organisational skills of the parents, and not all families are equally good at that. So the ketogenic diet's worth the consideration. But do I know about it specifically for CHD2? No, not really. I'm just trying to think if any of my patients have tried it. So I can't give you a direct comment about that.
Dr. Scheffer, I'm going to try to ask a question. So hopefully my video comes through. My daughter is on multiple ASMs, and she's been virtually seizure-free during the day for a few years now.
Right.
But at night is a totally different story. And could you talk a little bit about sleep and seizures and what's going on in the brain during the sleep time? And is there any kind of medication that we could give her to help protect her over the course of the night?
So the sleep is very activating for epilepsy and for epileptic activity. So many epilepsies are triggered by sleep. And many of the syndromes, the seizures are predominantly in sleep, such as Lennox-Gastaut syndrome, for example. Many of those patients will have a lot of tonic seizures in sleep, and they may have only 1 or 2 in the daytime, something like that. So we know sleep is activating. We think that the brain sort of becomes, when you're awake, you're inhibiting all the activity because you're alert and you're doing a whole lot with your brain. But when you're asleep, that inhibition stops, and therefore the seizures can sort of take over. So lots of seizures in sleep. There are drugs that you can tend to use overnight that might be more helpful, like clobazam or the benzodiazepine groups. And there are other approaches you can try. Just because you give medicine day and night doesn't mean it's not working at night. So it just needs very careful management, and being under a specialist that's good at epileptology, really, pediatric or adult epilepsy.
Great, thank you so much.
I think, Lauren, if you want me to ask this, we did want to get your input, Dr. Scheffer, on how important it is to have folks register with a patient data collection system and why that matters.
Look, I think it's super important. We're in the process of launching a large natural history study for the world, which is going to have a parent portal and a medical portal so that we know whose information we're getting and asking people to send their notes and etc. And the idea of that will be to share it with everyone. I'm more interested in natural history. I think registries are fine, but they're literally a name and a date of birth and maybe a gene variant, which is critical. You've got to know the gene variant, because a lot of doctors may misinterpret gene results. That's also something worth stating, that if you get a gene variant in CHD2, it doesn't mean it's pathological, or pathogenic is the word we use, which means it doesn't mean it's causative. That needs a whole number of steps to figure that out. And so we will see people who maybe have a variant and it's been incorrectly called as pathogenic. So it needs curation. Someone needs to be looking at these results and checking that. So I think registries are good in terms of, from your point of view, if you're talking about your own in-house registry, it means that you can then get access to people. They know what you're doing. They know if there are CHD2 trials, like the one I just suggested, you go ahead and get in fenfluramine. I just had, on the way to work this morning, it's 10 a.m. in Melbourne, I just worked with a person from a CBD company, and they're just looking at a trial in myoclonic tonic epilepsy. So that's where I would pull in all my children with MAE, including my CHD2s. And if they showed a good signal, the CHD2s, that would be exciting too. But to do a trial costs millions of dollars, as you probably know. It's not a small undertaking. So I think a registry from your point of view is very valuable to be able to get people quickly and get their answers. I don't think it's the same as a formal natural history study. And I would be very keen for anybody in your team, once ours is up and running, which hopefully will be in the next 6 months, that we can then bring anybody who wants to in, and then we can give you the data, obviously de-identified. So we would be open to sharing that with the right research ethics and all those sorts of issues. So that, but just a really cool example of the value of such a registry. I just tweeted on the weekend, I don't know if you saw, but the Dravet people did a lovely little thing through their registry of response to COVID-19 vaccination. And they've tweeted it out. And it's so helpful because here I am telling all my Dravet families, and I have many, go and get vaccinated as soon as possible, and here's the data to say it's safe. It's really lovely work. So, you know, I think the family groups can do very important work, but you've only got limited resources, and you have to think about what's the most useful question. And this was a really useful question that the US Dravet people could tell the rest of the world, you know, we know they tolerate it well. And I thought it was a beautiful example. And they showed, and I read it, and I came back to them because I'm on their medical advisory board, and I said, this is a critical question, can you answer? Or two actually, and one they can look into their data, and one they didn't have enough data. They didn't know who said what, so I couldn't go back and check a question. But I still just showed to me the value of good parent bodies, but it takes a lot of work, as you no doubt know. You're muted, Christine.
Absolutely, yes. It has been a lot of work, but we feel like we have covered a lot of ground in a short period of time, and we are just super excited to have experts like yourself being able to educate our community on what it is that we need to be looking for, and how to move this ball forward to eventually a cure. So we're super excited.
I can just remember when I mentioned to you that I've done follow-up work in SYNGAP1 and CHD2. I did CHD2 first, but by the time we did SYNGAP1, we had 57 patients. So it was much bigger. And I remember speaking at a SYNGAP1 meeting in the US a few years ago, must be 5 years ago now, because we published that in 2013. And this audience was 100 people, 150 people, of which more than half were parents. And I remember that I showed the videos, and the parents, most of the parents had children whose seizures were not diagnosed. They all went pale when I showed the videos, because they realized that everyone had been missing their child's seizures. So I think it is really important to have your community up to speed. And that's why diagnosis helps, because then you can recognize the seizures. And you know yourself, Christine, with the eyelid myoclonias, they're very subtle and people do miss them.
Yeah, I can't imagine what else we don't know about the seizures, the seizure types.
Good point, good point.
Yeah. Well, if there are not any other questions, I think we can wrap this up. This is being recorded, so it can be accessed at a later point. Lauren, am I missing anything? Do I need to cover anything before we wrap up?
No, I think you're good. Thank you so much, Dr. Scheffer, for your time. We appreciate it.
Great. Thank you, everyone.
Yes.
Have a good night,
Thank you.
America. See
You
you.
too.
Bye-bye.
Bye-bye.